Afternoon. Welcome to the Care 360 sponsored webinar, President-elect Trump and Healthcare, What You Need to Know. My name is Colby Dix, and I will serve as your moderator and host today. Extend a warm welcome to our presenter today, Mark Anderson. Mark's bio is up on the screen now, and you can see that we're very lucky to have someone with his experience. His 40-plus years of dedication to healthcare IT and consulting has earned him great renown in our industry. So we welcome Mark Anderson.
Well, thank you very much for allowing me to communicate with everybody on the line today. It's kind of an interesting subject with the inauguration going on this coming Friday. We're going to be talking about where we see healthcare going under this new Trump administration. So I think this will be a very good session for today. Give you some insights on what we know and really what we don't know so far.
And today's session is going to follow question-answer format of sorts, in which I'll be asking these questions of Mark, and he will provide the answers, that insight that we're hoping will provide quite useful. Today's topic is timely, to be sure, with the changes happening as we speak. The inauguration just a matter of days. In our industry, change does occur regularly, and it's hard not to feel some uncertainty with that political shift that's happening right now. While there are lots of questions that will be answered in the coming months, we'll do our best to address a few of the hot topics right now as they stand today. Mark, with the inauguration on Friday, we're about to see a shift in power in Washington. Could you give us a little insight on the issues that the new administration will have to address in the first days of their term?
Well, I think it all starts with healthcare costs. Everybody knows, and everybody's probably experienced, that healthcare costs still continues to increase at a level that no one can really sustain. I've seen numbers as small as healthcare costs are increasing by 6%. We've also seen people getting their insurance rates increasing by 50, 60% every single year. So something's going to have to change. We got to find a way of lowering our overall costs, and that's what the administration is really facing. Is it ObamaCare? Is it utilization? Is it the percentage of our population of chronic diseases? It's all kind of things. And I think as we're moving into 2017 and 18, we are going to see a movement away from traditional reimbursement for fee-for-service and moving towards a different type of financial model based on quality and outcomes. And a lot of people are calling that value-based reimbursement. It's a financial model people are looking at. But we're looking at different ways of doing things to lower the overall cost. Everything we've tried the last 20 years has been great for medical conditions, but our costs keep going up. They're unsustainable, and we're not doing a heck of a lot around improving the overall health of the population, which is what we're going to have to do if we're going to try to lower some of the costs. These are numbers you've probably seen before. The numbers of dollars being spent by CMS is increasing. It's the same thing for Aetna, the Blues, the Cigna. Costs just keep going up tremendously. A lot of the employers are reporting that their costs are going up by 50%. And realistically, for an individual, it's very hard to get your private insurance. I'm a small company. I'm not big enough to be able to get very large insurance plans. And, you know, my insurance plan just said we're no longer going to be supporting individual plans. That's one of the programs. I won't say who the insurance company is, but they're no longer going to support it. And therefore, my rate for me and my daughter went from $650 a month to $1,250 a month starting in July of this year. Now, that's doubling of a rate. And realistically, the rates have been going up way too fast, as well as the percentage of money paid out by the family. So if you go to the next slide, I've got a little diagram of that, of how much money the actual, we call millennium-type people out there are paying for health care. So if you're a family of four, husband and wife with 2 kids, you're seeing how much you're going to be spending today and in the future. And can we really be spending, $22,000 a year? Again, some of these numbers are a little bit old, but can we afford to spend this amount of money for out-of-pocket and for insurance payments for a family of 4? $22,000. That was in 2013 for the average family. We've got to do something differently. And a lot of the deductibles have increased from $1,000 to $7,500 per person. And that's before the insurance companies pay any money out. You got to pay that first $7,500. So why are we paying, $1,000 a month for insurance, and they don't even pay anything until this first $7,500? That's what's not sustainable. People cannot afford to have this kind of stuff. And it's not because of the Obama plan. It's not because of anything. It's because our costs keep going up, and we have to find ways of controlling the costs. And that's what the administration is going to be seeing. And probably the first 100 days is what kind of programs can we implement that are going to help control the overall expenditure on healthcare. And why is it important? Let's look at the next slide. We are still way above all the other countries, almost twice as much as most of the countries, the developing countries out there, on what they're spending for healthcare. And one of our problems, I think, is that we're still rated 21st in the world as far as health. And is that because we don't provide good health to our people? No, I think we provide very good health. We provide great medical care. One of our problems, though, is why do we have so many people with chronic diseases? Over 38% of the population have a chronic disease today compared to other developed countries. And that's going to have to change a little bit. I'm not sure how we're going to change that. But people with chronic diseases are driving 65% of all of the costs today. And we have to take care of that population to make sure that they're staying healthier. And there's nice programs we can do around clinical alerts, best practices, care coordination, and patient engagement to help work with those people with chronic disease to help control the costs. So I think that's what they're going to be facing in the beginning, is how they're going to be able to find ways of lowering the costs without taking people off of the health care plan and making sure everybody is covered in some way for health care. There are things we got to think about. We need a fundamental structural change in healthcare, and we think it is going to be shifting. Healthcare has always been considered a cottage industry. Small hospitals, small physician practices, all working with the local community. We're seeing it no longer being this cottage community and becoming a much larger healthcare organization. We've been hearing about all the mega deals going on between the mergers of the big healthcare plans, Aetna and Cigna, Aetna and Humana, Dignity Health and Catholic Healthcare Initiatives. There's all kind of things going on. And, personally, I was involved in a hospital system that got bought by Catholic Healthcare Initiatives back in September of 1997. We were the first 10 acute care hospitals Catholic Healthcare Initiatives bought. And since then, now there are 105 hospitals and about 33 critical care access hospitals. So we're seeing the hospital system becoming bigger, more consolidated. We're seeing the healthcare plans becoming bigger, more consolidated. And we're seeing a lot of the physicians that are in rural areas staying somewhat independent, but physicians that are in urban communities like Los Angeles, Chicago, New York, Atlanta, Los Angeles, are now being employed by the hospitals. And these are hospitals with multi-hospital systems. So again, the healthcare future is going to change, and it's going to change in the next couple of years, hopefully for the better as we keep going. And I just want to show you one slide on the next slide that goes, it kind of shows you what's happening with the number of physicians employed. Again, this is more for the urban areas and what they're seeing. And we're, again, the data is always outdated for some reason. I'm not sure why we can't get newer data. But we saw that around 2009, that we started seeing more and more physicians employed by hospitals than the being independent out there. And again, in the rural area, I think they're still pretty well independent, but in the urban areas, we're seeing more and more of the physicians being employed. And that's going to affect how we run our businesses in the near future, especially as we move to value-based reimbursement. The other part we're talking about, obviously, is all this discussion about all these lovely terms, MIPS and APMs and MACRA and everything. The government is still requiring us to move towards what they used to be calling Meaningful Use Stage 3, where they've changed the letters, and they now require different type of reporting. But the whole question is going to be is, how are we going to be driving all this? With MACRA payments to physicians, it's going to be coupled with mandated bundled payments for people with chronic diseases like heart failure, coronary artery surgery. And I've just got off a phone call with a bunch of orthopedic surgeons on their joint replacements programs and how the bundle payments are coming together. They're going to have to figure out how to handle the physician side and the ambulatory surgical side or the hospital side for joint replacements. How do we provide a better quality for a lower bundle price cost? We got to find the ways of doing it. And really, it's what the future is going to be. We have to get ready for it. And I think value-based reimbursement, what some people are calling, quality and outcomes healthcare, is going to be the wave of the future, because there's incentives for the healthcare plans, Medicare through CMS, Medicaid, and in most cases for larger healthcare groups to be very active in value-based reimbursement. We're just going to have to see how it affects the small physician office, because we don't want them left out of what's happening in the near future. So I think some of you have been on some of these presentations I've done before. We've been talking about value-based reimbursement. And if you don't know what it really is, and this is the thing that the CMS has embraced, ObamaCare basically embraced this, and really the Trump administration has said the same things. We got to find ways of lowering the cost while improving quality. And it appears to be this quality-based, outcomes-based, or as we'd like to call it now, value-based reimbursement model that we're moving to. Where in 2010, fee-for-service was about 80% of all payments. In start looking at 2020, we think it'll be less than 20%. The government's already stated they're moving 50% of all Medicare payments to some kind of quality, outcomes-based, value-based reimbursement model by 2018. And for the government, that means starting October 1st of 2017 is when the fiscal year starts. So we're going to see a lot of movement starting really in 2018. But this is the year everybody's going to be talking about how do we move towards this new reimbursement model around quality, reporting outcomes, and it's all about creating value for the quality of healthcare we're providing. And the overall push obviously is to improve health, reduce costs, and improve the patient's experience so that when they get out of having a physician office visit or they finish their surgery, they feel things are better. They're happier with their health, overall health. And I think it's going to affect a lot of the physicians the next 3 to 5 years, because we're really moving towards just major insurance companies contracting with healthcare systems to treat patients with chronic conditions, kind of a capitated model, not for all patients, but with the 35 to 38% of the population today that has a chronic disease. And if the physicians are not connected to these healthcare systems for quality, care coordination, patient engagement, physicians could get left out. So again, if you're a physician out there, obviously, you want to be very proactive and get heavily involved in figuring out how you can be part of these systems and find a way for proving that you have the best quality and the best outcomes in your community. You're almost going to have that to bring all of that together. And as we think competition for this non-traditional healthcare, for instance, micro hospitals, retail clinics, telemedicine programs that are going on out there, urgent care centers. These are things that are going to be driving some changes to healthcare. And we have to figure out where where Trump is going to be looking at how he's going to be supporting these. How many of you have seen these freestanding ERs opening up across the country? Estimates that there are over 10,000 new facilities open since 2015 that are called an emergency room, not connected to the same facility as a hospital. How are those going to be regulated? Are they really part of the hospital when they're not connected to the hospital? We've seen a lot of these are 10 miles away from the closest hospital, but they're called an emergency room. How are they going to be reimbursed? And how is Trump going to either support them or control what they do? Again, it's a whole new avenue out there. We'll have to see what really goes on in the next couple of years. But the first 100 days are probably going to be the biggest issue that we're going to see today. The big issue that they're facing today, and you're hearing everything they're talking about, is the Affordable Care Act, or ObamaCare. As we know, half of the people in the United States think that it's the best thing out there, and half of the people think it's the worst thing out there today. And I think it all depends on where you sit in. If you're a low-income person, now you can get health care insurance subsidized by the government and pay a very small amount to get that health care. If you're somebody with a chronic disease and you have a pre-existing condition, you'll no longer be taken off of your health care plan if you decide to change companies. You can keep your health care plan today. The problem has been, as we've already talked about, the costs are going up tremendously. We're seeing 40 to 50 to 60% increases in rates each year. We're seeing deductibles increase, as I mentioned earlier, from $1,000 to $7,500 per person. And we're seeing a lot of the healthcare plans pull out of the market where there is no competition anymore. I know here in Texas, if I want to get on one of the programs that matches the ObamaCare's requirements, there are only 2 programs left now, and they are very high cost. In one case, the cost just for me is $1,300 a month for insurance. Who can afford that as an individual, especially with a $7,500 deductible? But there's no competition anymore. And the goal of Trump has been, let's create competition. Let's allow insurance companies to sell their insurance over different state lines. A lot of things can occur. But one thing that, of course, Trump promised last night was that everybody will have access to insurance. The 12 million people that are covered under Obamacare will have access to insurance going forward. Now, a number of people have been commenting on that since last night, saying, how is that going to happen? How can we provide insurance to everybody at a lower cost? We've not been able to do that in the past. We'll have to see how they come up with it once we know more about the Trump's actual plan. There's not really a lot known about the plan right now. It's concepts. They're working on it. And we'll have to see what kind of detailed proposals come out in the next couple of weeks. And I think it's going to occur after his cabinet positions are approved by Congress and the Senate.
I think that's that's some great info, and it's going to segue right into question 2 here. But you know, as you did mention, with the Senate vote earlier this week in favor of budget reconciliation, you know, there was definitely a clear message sent in terms of the ACA and its potential to be repealed. I know it's a lot of kind of crystal ball at this point. I may say that more than once here today, but can you speak to what you do know or about President-elect Trump's proposed agenda for our healthcare system moving forward?
Yeah, I think that's probably the biggest question out there now. We've heard generalities. We've heard Trump make statements, or a lot of times it's just a tweet that he still does talking about it. They have promised to repeal and replace ACA on the first day of the office. Now, that is not going to occur on Friday. That'll occur sometime after. But again, I think the mechanism for doing this is there now, but they're not going to do everything on day one. They may start the process on day one, because the question is how? How are they going to be able to replace it? What are they going to replace it with? More than likely, there's going to be, from what we can tell, probably no changes until at least July of 2017, but the process will start. They're going to have to figure out, of course, cabinet members have to be appointed so far. They have to come up with a plan. It has to be through the Congress, and the Senate have to approve before it goes to Trump for his signature. There are a lot of different ideas out there. And to date, we have not seen the detail behind the ideas. There's concepts. One of the documents I saw was replacing Obamacare. Remember how many pages? That was thousands upon thousands of pages. There was a document that came out a week ago that only had 20 pages to kind of explain what the concepts would be. It didn't get into all of the detail, but it was a good overview of what we think might happen. And it's going to be a big question, again, on what are the details behind it. For example, can kids under the age of 26 stay on their health care plan? Appears that might still go through. Can you sell insurances over state lines? That'll be something that'll definitely go through, according to Trump. Will people that are on Obamacare today still have access to it? Well, there's a lot of conversation about that. Again, last night Trump said, yes, everybody that's covered will be covered. But again, it's going to be how. How do they get there? How do they find out exactly? That's what we don't know. And it's too early. People expect that the information is going to be out there in detail right away. And I heard a lot of comments about the Republicans wanted to replace the Obamacare for 8 years now, or, you know, and where's their plan? there are numerous plans out there, but they want to get both sides to agree on a plan as soon as they can, and that's just going to be a lot of back office dealings, figuring out the best way to do all this, finding the best of Obamacare, keeping that, and I think eliminating certain things under Obamacare that has been very costly. For instance, the requiring a health care plan to cover so many things that certain people don't need. I may only need a critical hospital health care plan. I may not need a comprehensive health care plan. I should have choice over what I pick. And today, the minimum requirement for all health care plans have increased costs by 40 or 50%. So if we get rid of some of those minimums that certain people may not need, then maybe we can lower some of the costs. But all those things are going to be figured out. And it's going to take a lot of work to get everybody to figure out how they're going to be able to replace all of this. So again, once they figure all this out, they vote on it, they come up with something, what's going to happen then? And I think the first step is really going to be the dismantling of this healthcare.gov program that was been out there that was, of course, a disaster in the beginning, and really transitioning the control of the marketplaces to the states. Trump has always made comments about how he believes healthcare should be controlled by the states, especially around Medicaid. And if you're living in a certain state, you should have certain things that you need. And we should, if somebody's living in Arkansas, they shouldn't have to pay the same rate as somebody living in New York City. So I think they're going to push a lot of the requirements and some of the funding back to the states to cover a lot of that. But again, I think the healthcare.gov website and everything it was doing is probably going to be gone in the very near future.
In knowing that Representative Tom Price, as the presumptive Secretary of Health and Human Services, he's been sort of planning for this eventuality for quite some time, and even, certainly brought to the discussion House floor at least 4 times, brought up sort of his plans, as it were. So having him as a presumptive Human Services Secretary is something that I think, we might have a little bit of insight into what happens next based upon some of his previous proposals. Do you think that, between the information from what he's already put out there, plus what we can essentially presume, do we have a better idea of what kind of options there are for that repeal and replace? Like what kind of a little deeper into the negotiation aspect of that?
I think we do to a point. Price made a comment last night about how he does not want his own personal opinion on the replacement, his plan, to be driving the decision on the congressional review of appointing him or not, or agreeing to it. I think he's got some really good ideas on how to handle this. And the question is going to be is, he'll take those ideas, they'll make modifications to it, and then it's really about all the dealings that go behind the scenes in the Congress to get everybody to agree. And again, we don't need 100% of everybody to agree. We only need 50% for approval. But there's certain aspects of Obamacare that do require 60 votes in the Senate. Therefore, he's going to have to get some of the Democrats to come across and to hold on to all the Republicans. People think that's possible, but again, it's all about the detail. And it's all about how do we take care of certain populations. And it always comes down to that. And the main concern is making sure that the 12 million people that are now on Obamacare can have some kind of health care. We're not taking something away from them. None of this is going to affect Medicare because, Medicare runs on its own, and the question is going to be there is how much additional funding do we have for Medicare each year? So it's not going to affect anybody that's on Medicare today. It may change some of the Medicaid requirements in each one of the states so that the state can decide what their Medicaid requirements are, what the dollar amounts are, and how they fund it and how they operate it. But for sure, a lot of the discussion has been around how do we make sure that the patient becomes active in their own health care. If we've got people that have chronic diseases and they don't follow the physician's recommended plans, they don't follow trying to, eat differently or exercise more, do something differently. What we have to do is find a way of encouraging the population to get engaged in their own health care and trying to improve. We can't do anything to lower costs if 40 or 50% of the population in the United States will not follow the plan that was put together by their physician and their healthcare system to try to stay healthier. There is no incentives today, except for personal incentives, to try to stay healthier if you've got a problem. And that's where some of the legislature, I think, issues will be. How much do we put the responsibility on the individual person for their overall cost? You think about getting your insurance for your car. It's based on your driving, how good you drive, how many tickets you have, how many accidents you have. Your life insurance is based on, your rich life insurance is based on your health. Do you smoke? Do you drink? What else do you do? Why is health care a privilege that doesn't matter how you actually interact with the community and your own health? Should the person who has a diabetes that has their A1C value in control, they exercise, they've changed their diet, why should they pay the same amount as somebody that's a diabetic patient that is obese, who doesn't try to do anything, doesn't follow any of the recommendations? Why should they pay the same amount? And that's probably one of the most controversial parts. How do we get the patient engaged in their own health care, and how do we get the patients that are not compliant to pay a smaller percent of their health care than the people that might have a chronic problem but are engaged and trying to do the best they can to lower their costs? We got to find a way of getting the population involved in their own health care going forward. So a lot of that's part of his plans, part of how we're going to change things in the future. We'll have to see how well they can get there over the next couple months.
Mark, on this one, I don't know, you didn't speak to it directly, but the second point on the importation of prescription drugs, specifically,
yes,
as that one there, I mean, with the recent Senate vote to block the importation of drugs from Canada, does that affect or lessen that likelihood? I mean, there was 13 Democrats did vote against that as well. It wasn't purely partisan, and I think, at face value, it's hard not to see beyond the power of big pharma and the lobbyists on an issue like that. But do you think that there's still some light there as far as that point goes?
Yeah, I think there is, because basically in most cases, the drugs that are over in Canada are a lot cheaper for the exact same drugs here in the United States. And why is that? And Trump made a comment the last couple of days, might have been over the weekend, about how he definitely agrees we need to renegotiate drug cost. And especially starting with Medicare, what are we paying for Medicare drugs? There are ways of lowering the overall cost of medications. And last numbers I saw, about 22% of all healthcare costs are related to medications, either chronic medications or anything off the shelf or prescriptions. We have to find ways of controlling that cost. Numbers that I've seen is that healthcare costs are increasing, but the costs for medications are increasing much faster than any other segment of healthcare today. We have to find a way of controlling it. Now, just importing drugs from other countries without the control is somewhat dangerous potentially. We have to make sure the drugs are effective, the exact same drugs. Of course, the average person just sees a purple pill. They don't know how good it is compared to another purple pill. But we do know that pharmaceuticals are making a lot of money off of the medications. But again, they make money so that they can invest in looking for new medications that are going to improve things. But we have to find a way of figuring out what medication provides the best outcomes, the best results. And I think as we move to value-based reimbursement, where the healthcare system, the hospital and the doctor gets a capitated amount of money to take care of that patient, let's say a diabetic patient, then it's up to them to figure out what medications provide the best outcomes for the best price. And they're going to be looking at that where we never really looked at before. We can order the most expensive medication or the cheapest medication. We were never held responsible for the overall cost of how well did that medication actually work. So I think there's going to be a lot more review of medications around quality and cost. Does that $1 pill provide just the value as a $50 pill? Those are things that are going to be determined, I think, in the next 3 to 5 years, as hospitals and physicians are now held responsible for the overall outcomes of a patient, and they're responsible for the cost of that outcomes. They're going to be looking at a lot more ways of reducing costs, and medications is a big area they're going to be going after.
Let's take it back a step once again, and we'll talk about the first 100 days of the presidency. And if you don't mind speaking to some of the first steps that we're likely to see, and then some expectations a little beyond that, you know, the first month or so, and something that you'll see, you know, within that first 100 days, as it's called.
Yeah, obviously and he's already started trying to get his cabinet positions put together. We're talking about he has to appoint over 4,000 different political appointees, and he started that process. But you got to get the cabinet done first, because that's the starting point. So in the first 100 days, a lot of this is going to be about making sure they get the political appointments to the cabinet and key agencies and programs put together. And they're going to have to, you know, talk to a lot of people in the lawmakers in Congress to figure out who are these people going to be, who's going to be in charge, and to make sure we understand exactly what their positions are, because there's still a lot of controversy over, you know, Trump being the legitimate president. As we've heard a lot of discussion about that in the last weekend with some of the congressmen. And we got to find a way of getting his cabinet positions appointed. And obviously, as we've already talked about, Tom Price is the one we're thinking at for the Secretary of Health and Human Services, and another person, Zelma Verdman, looking at taking over Medicare, the CMS side. And their names are on the next slide if you haven't seen it yet. But I think that is where the president really needs to spend a lot of his time. There are over 200 key healthcare slots that he's going to have to appoint. But again, you got to get Tom Price in and Selma Verman in before we start looking at the second, third, and fourth level people. Because again, they're the ones that are going to be driving the decisions and the guidance of where we're going to be going in healthcare. And a lot of that will depend on them getting approved, and what are they going to do that first couple of weeks once they're in charge. And I think we have to go back and look at each one of them and see really where they come from. I don't think a lot of people really know where Tom Price comes from. And you think about it, he's the chairman of the House Budget Committee. He's also an orthopedic surgeon. So he understands the healthcare side of things. 4 times, as I think you mentioned, that he's actually provided some legislation to replace the Accountable Care Act. He has a plan of what he'd like to see. And I think a lot of us have seen parts of that plan, but I think sooner or later we got to get all of Congress to start looking at what his plan is and working with other congressional people to come up with a final plan. But again, his plan is really about 40 pages long. It's a lot easier to read than some of the other plans that are out there. And again, last year he was the chief sponsor of the only Accountable Care Act repeal bill that ever reached the White House. But of course, as we all know, President Obama vetoed that one. So again, it's a tough one. He's got a lot of experience. He knows what to do. He's been in Congress for a while. And I think he's going to provide a real good insight on what's going to happen on what healthcare is going to be. And it's all going to be about quality and outcomes going forward. Now, we also got Selma Vernon, who's taking over, hopefully, for CMS. And it's interesting here because she's really a consultant, a healthcare consultant out of Indianapolis, Indiana. And she's been working heavily with redesigning the Medicaid programs, kind of an experimental program under the Accountable Care Act that Obama administration has allowed. It's based on a bunch of new ideas where the beneficiaries should be required to take responsibility for their health and their finances, what I mentioned earlier. How do we get the Medicaid patient to get more actively involved in their health care? And the programs she's put together have been very successful so far. And she's been advising a lot of the other states, mostly Republican governors, on how their Medicaid program could work a little bit differently by providing incentives for the patients to be involved in their own health care. I think we're going to see a lot of this with telemedicine, patient engagement, care coordination between providers and the community. A lot of things can occur. And I think we have a lot of people with brand new ideas that will save money, built around outcomes and quality improvement.
I think that's a really salient point. I think there's a sort of an anecdotal feeling that there was a lot of responsibility passed on to the practices and the hospitals with the Affordable Care Act, without giving that level of responsibility to the end user and the patient and the actual recipients of health care in a way. And I think that that alone is going to be one of the driving factors with these changes.
I agree. I think we start thinking about what percentage of a physician's, meaningful use stage 1 and 2 were controlled by patients not engaging. They weren't compliant with what the doctor said. Now we go to stage 3 with MACRA and MIPS, and are we going to penalize hospitals and doctors because the patient won't be compliant? They won't do what the doctor tells them to do? And can a physician so-called fire a patient? Can they eliminate a patient out of their practice if the patient's not compliant? There's a lot of discussions around that. So you're right. We need to move so that the physicians and the patients are jointly working together to lower costs and improve quality and health, not just making it the physician's responsibility to change how a patient wants to handle their own health. The slide is something right now. I think it kind of gives you an idea of, what they're talking about on the low-hanging fruit that's out there. And one of the things they've really talked about, Trump has really talked about, is what can he do for veterans' health programs? We got to find a better way of handling our veterans out there. People have been complaining about that for years. We've seen all the congressional reviews, all the studies that are out there. And, we got to find, again, better ways of doing things. It really comes down to workflow efficiencies, but taking care of the person more responsible, treating them like a person, not just a number in a healthcare system. And, of course, one of the other issues that'll be tackled, I think, is the elimination of what's called the Cadillac tax on employers and medical device tax as a good starting point. We under ObamaCare and Affordable Care Act, they've added this big tax on top of all medical devices. Well, the medical devices are the things that are tracking patients' conditions. Why is there an extra tax on all of those? We can get rid of that tax, we're going to lower the cost. And of course, part of the plan was, well, if we tax everybody, there's more money to pay for Obamacare. But they're taxing the wrong things, I think. A device tax is something that's not providing a lot of value to anybody. It's making it tougher for people to buy medical devices for monitoring, especially as we're looking at remote monitoring of patients' conditions. To be healthy, we need to know how the patient feels on a daily basis. We can't wait for the patient to show up in the doctor's office once a quarter or once every 6 months. We need to get data about how that patient's feeling on a daily basis. If a diabetic patient gains 2 pounds from day 1 to day 2, there's a 70% chance they're going to have an ER visit in the next 7 days. That's data that we know is out there. We got to be able to find ways of collecting that data. Medical devices are the way to do that, and we should not be taxing medical devices at a rate that actually makes it too hard for anybody to buy. The other one is the Cadillac tax, where if you're providing a very good health care plan for your employees, there's a tax on top of that. So we seem to be taxing everybody and not thinking of it as what is the best health care system. So I think eliminating the Cadillac tax and eliminating the medical device tax are things that they're going to be looking at probably in the first couple weeks. Low-hanging fruit that really won't affect too many things, that may make it easier and less costly for certain programs to keep going. Everybody likes to say the honeymoon for a new administration is very short. This is going to be a very long and bitter campaign, probably even longer and more bitter than the actual election process we went through. Trump is really unknown on Capitol Hill. And, uncertainty abounds everywhere, and people are questioning, what's he going to do? How is he going to do it? You've got the Democrats fighting everything that he's talking about so far. He's not even, he's not even in the position yet. Lines are drawn, and we're going to have to find ways of getting the cabinet positions approved and have them try to break down some of these barriers that are up there. Everybody complained about Trump talking about building the wall over Mexico. What we're seeing is a lot of walls being built up right now in Congress, that everything that President-elect Trump is stating, they're putting barriers up right away, saying it can't work. Everybody's going to have to step back and see. Let's see how things work. Let's see how things are going. Give him a chance to come up with these programs. They seem to want to fight everything day one without even seeing what the plan is. And I think what we need to do is the plan's has to come out in more detail so people can critique it. But let the plan come out. We got to see what the plan is before we start fighting everything. We got to stop this fighting between everybody and come up with something that everybody agrees with. And of course, the next big thing after the health care is going to be other issues. The Supreme Court vacancy that's still sitting out there, left by the death of Justice Scalia. That's going to be a big issue, a big fighting point for a lot of people. And that'll be the next thing I think that people are going to be talking about after health care is the Supreme Court position. So I think that's going to be a tough one too. But that'll be the second area that he's going to be working with.
Yeah, on the topic of the Supreme, On the topic of the Supreme Court vacancy in particular, there are at least 4 cases directly related to health care that will be considered by the Supreme Court in the coming year, which, that doesn't necessarily mean that they'll make it to judgment, but in light of Zubik versus Burwell this past year being sent back to the lower courts, essentially reaffirming states' rights, which we mentioned a little bit earlier, but that was in regards specifically to the contraceptive mandate within the ACA. Do you see that as a potential trend? And without asking you to, look into the crystal ball again, are you aware of any of those upcoming cases that are likely to affect us in healthcare specifically in the coming year?
Obviously, it's going to depend on who he nominates for the Supreme Court and how tough it's going to be to get through. But from everything we've seen with Trump, he's not a Republican. He's not a Democrat. He seems to be somebody kind of in between, even though he's obviously the Republican nominee and president-elect. But he seems to have his own way of doing things, and it'll be interesting to see who he picks. But from all indications that it's going to be away from government control of healthcare, more towards putting more responsibility on the state and the individual for their own healthcare and their own health. So whoever he recommends and gets approved, I think it'll be somebody who believes in not big government, allowing the state and the individual to make the decisions where, okay, government will be part of it, but they're going to be the ones obviously controlling Medicare. But anything outside of Medicare, I think it's going to be more allowing the person and the state to be involved in their own decisions, not something that's going to be government forced upon you. And it probably will not be universal health care under one health care plan, what a lot of the Democrats really want it. So it'll be interesting to see, but I think a lot of this will be changing over the next, 6 months or so. Things will come back to the Supreme Court to deal with some of these issues, but I think it all looks pretty healthy that we're going to be looking at these things a little bit clearer, and hopefully it'll be going to the right direction for everybody. But until we see the actual detailed plans and the plans get approved and we see 6 months of implementation, we really won't know how well it's going. But no matter what, I think more people will have a different opinion of the ACA and Obamacare maybe a year from now if they see another program that's running better. Right now, we see the old system that really didn't work, and Obamacare that works for certain people but not for a lot of people. We need to see a new plan. And like I said, you got to see it working for 6 months to a year before we know how well it's working. Obamacare looked really good in the beginning, and then as the rates increased, didn't look as good to a lot of people. So the question is, give it a chance. Let's see how it goes. But we have to hold everybody responsible for what their decisions are this time. We can't just let it go for 4 to 8 years. This is going to have to work the right way this time, lowering costs allowing access to healthcare, and improving overall health communities as we go.
Well, let's pivot a bit, and we'll talk about the implications facing key stakeholders in our industry. As we have mentioned, there does seem to be a bit of a responsibility shift going on, both in our direction as providers and in our evolving healthcare system. Can you go ahead and speak towards that and other significant projections?
Yeah, again, it kind of comes back to what CMS stated about moving 50% of all the Medicare funds to this value-based reimbursement model around quality. Medicaid, the Blues, the Aetnas, the Cignas are doing the same thing. So the key stakeholders are going to be the physicians and the hospitals, and realistically, you got to put the patient in there too. The patient is a stakeholder for their own health care. But I think there's going to be a role for the federal government and state to oversee a lot of this stuff, but it's going to be more driven locally by the state and the local businesses and the people on getting their own healthcare programs in order. Cost containment is going to be a big issue. How do we lower this cost? And it cannot be that we're going to lower it from a 12% increase each year to only 6%. We've got to find a way of actually lowering overall health care. And again, through this value-based reimbursement models that they're proposing, there's a very good chance that we can actually lower costs finally instead of having a lower increase in cost, which really doesn't get us anywhere. But the only way we're going to be able to do that is if we can improve outcomes. We can find ways of keeping people with chronic diseases a little healthier. The 65% of the population that does not have a chronic disease that are considered generally healthy, they're already healthy. They don't spend a lot of money on health care. They're spending way too much on their insurance for what they're getting back. If it's a medical condition, you get in a car accident or you trip and fall or something, the interesting part is a lot of that stuff's not even covered under your medical insurance. It's covered under your homeowner's insurance or your auto insurance or your workman's comp insurance or other kind of things. So we got to find ways of controlling the cost by improving quality of outcomes. And as we know, 35% of the population affects 65% of the cost. Let's concentrate on that population. What can we do for them around best practices, clinical outcomes, patient engagement, remote monitoring of the patient, even telemedicine programs, where we all get involved in that to overall improve the health of it so that everybody benefits from this. The physicians find ways of taking care of patients better. Maybe more and more physicians are going to be moving to some kind of telemedicine program, telehealth program. We're seeing patients so they don't have to drive all the way in to see a specialist. I think we're going to see a lot more on remote patient monitoring so that the physician can see information about the patient from their home or from their just walking around. How many steps do you do per day on your Fitbit? All those kind of things are going to benefit everybody as long as we can get the right information to the right physician at the right time on the right device. And, the movement to this EHRs over the last, 10 years has been a good starting point, but too many doctors are spending a lot of time collecting data and not really getting the value out of that data. Remember, 32% of all data that is collected on a patient has already been collected by somebody else. We have to find a way of getting the data about a patient, the clinically important data, to all of the providers. Sharing of the clinical information, no matter where that patient goes, if they're seeing a specialist, a primary care, urgent care center, they go to a long-term facility or assisted living, we need to share that information between all the providers. Why have the provider ask the same information multiple times and have to write it all down? That's ways we can do to really find ways of cutting costs and making it easier for the stakeholders by getting rid of a lot of the duplicate data entry, duplicate reporting that we have to do every single day. It's way too much information that we're collecting that we don't necessarily need. The other part's going to be identifying gaps between healthcare services and really human services, between the physical and the mental health. And I think that's one program I think that did benefit the ObamaCare ACA program, is that finally people with mental health were also covered. I know, like for instance, my daughter she goes into the doctor and she says, I have anxieties and my stomach really hurts, it's not covered by the insurance company because it's an anxiety, it's a mental issue. If she walks in and says, my stomach hurts, then it's covered under the health care plan. But if you mention anything about anxiety or anything relating to medical health, it wasn't covered under our medical insurance. At least it is covered now, and I think that's been very beneficial because there is a direct relationship between your mental health and your physical health. And I think people have known that for years, but since mental health was a separate carve-out insurance, it was never covered. And therefore, you know, if you have a medical issue that might be also affecting your mental stability, we need to find a way of covering all of that. And we have to find ways of being more open, more transparent, I guess you want to call it. You know, how we operate, how we negotiate all the deals that are out there, who wins and loses on these things. If a medical device company comes up with a great device that overall reduces costs and lowers the overall health risks, then you know we shouldn't be penalizing them. We should be embracing that kind of technology. If a new medication comes out that proves to lower costs and improve the overall health of a patient, we should be embracing that, not taxing it and making it harder for people to get. Or having, you know, we've heard a couple of those cases where a private company buys out a certain medication and does a 5,000% increase in price because they think they can do it. We got to get away from all those things. It's got to be a lot more transparent. And that's what Trump is basically saying. He wants everything in healthcare to be a lot more transparent, where everybody can see what's going on. We know what the costs are. We know what the results are. We know what the quality is. What are best practices, and how do we implement those? That's what President Trump wants to really want to see in the near future.
Very good. So healthcare CIOs and healthcare professionals probably have quite a wish list going at this point. Definitely some good things happening in healthcare IT, and definitely some pain points that are affecting all of us. If you don't mind, touching on some items that you're hearing the most about right now, Mark.
Yeah, again, these are healthcare CIOs, so these are the people that are running the IT departments of hospitals. You also have CIOs that are over large medical groups, you know, the Kaisers, the Mayo Clinic, Scott White Clinic, and really there's a lot more we're finding now, larger physician groups coming together, and they've got their head of the IT department. They're not called chief information officers, but, you know, they're still pushing a lot of things we've been talking about for years. National data standards on a lot of this stuff. We have a lot of interoperability standards that are out there. People are becoming much strong on that, but still very hard to exchange data between different provider organizations that are on different EHR products. So we got to come up with better ways of standardizing the care, coming up with best practices, especially around care coordination, patient engagement, remote monitoring, and tie all that together, and then make it all of that data interoperable, so that no matter where the patient goes, the data is collected and it's viewable by any provider treating that patient, no matter what technology they're using. We still have way too many silos of information where the primary care doctor's software product really doesn't talk to the specialist and it doesn't talk to the hospital system. We got to find a way of having all that information flow seamlessly. And we got to break those barriers down, that wall that's set up there where the EHR vendors really don't want to work together. The doctors don't really want to share information. Or in a lot of cases, some of the doctors don't want to receive information from other doctors. They don't think it's reliable. Somehow we got to break that barrier down. And we really got to look at this whole thing of this meaningful use reporting for the hospital side, for MIPS and MACRA requirements in 2017. It's nice to have reporting requirements, but who's benefiting from it? You know, we spent $52 billion on this meaningful use incentive program. Have we received any actual benefits from it? Has quality improved? Most people say no. Has outcomes improved? Many people still say no. And I think there's been some good advances. We have much better quality reporting, but is it lowering cost? Not yet. So if we're going to keep these reporting systems, somebody has to go back and look at, are we reporting just to be reporting, or are we reporting to find better ways of doing things, better clinical outcomes, better best practices? That's what we should be getting out of collecting all this data, is better ways of treating the patient with lower costs and better outcomes. not just reporting data to some government agency that does nothing with the data. And I think the CIOs are really talking about new ways of advancing technology. As the slide's showing here, the care coordination between all the providers, having a single view, called a 360 view of the patient. No matter where the patient goes, everybody can see the information, the correct information, at the correct timely positioning of the data. You know, we don't want to wait 3 weeks to get the data for the patient went to see a doctor and got an MRI done. We need the results. Everybody that's treating that patient needs to see the results immediately. Real-time information shared between every provider treating that patient with the confidentiality and security and cybersecurity we're going to have to look at to make sure no one's breaking into these systems and getting access to data that they should not have. So all of that will be discussed, I think, in the next 6 months, too, under the Trump administration.
This leads us to the always present question of what's next, even beyond repealing the ACA. There's a number of high priority items that the administration is looking at that either inadvertently or directly will affect us in the healthcare industry.
Yeah, you know, and you look at what Trump, his whole campaign was about immigration laws, you know, building the wall type thing, tax reform, basically tearing apart the whole tax structure, coming with a whole new tax structure for that. He's talking about really reinforcing the military, building up the military much bigger than it is today so that we can control the events across the world, no longer being disengaged in the rest of the world, but engaging with the rest of the world. And infrastructure improvements. These are the four, outside of healthcare, basic stuff he's talking about he wants to do a lot on. A lot of this will depend on his cabinet picks for these people, too. Because, again, the cabinet are the people that actually do a lot of the work with the Congress and the Senate to get these bills approved. They're the ones who come up with a lot of the concepts. But, again, remember, the laws are put together by Congress and the Senate. And the president and all his cabinet members basically sign off on these laws, but they have a lot of influence over what laws and how they should be written. But again, it's up to Congress and the Senate to write the laws. There's not going to be as many administrative mandates that Obama did, where he basically sets his own rules, sets his own laws, and makes them in practice. I think Trump is not going to do those kind of things. But it's all going to be about his cabinet positions, and really the 4,000 appointees he has to make in the next 3 to 6 months, those 4,000 people working with Congress and the Senate to come up with laws, rules, guidelines that are going to affect the whole industry. And obviously immigration is a big issue there. Certain states are spending a lot of money on health care for illegal aliens that may or may not be contributing tax dollars, and that's a whole debate always out there. Everybody wants to see tax reform changed, where people are paying way too much for certain taxes, other people are getting away with not paying anything. And again, his approach of let's bring a lot of the businesses back to the United States and providing some financial incentives to keep their businesses here. And literally every day we're hearing about an auto industry company bringing business back to the United States, which is going to bring tax dollars, employment, federal, tax dollars coming in for the salaries. Many things can happen when we're bringing more dollars in by bringing business back to the United States on the tax reform. As I mentioned, military reinforcement, I think there's a lot of people talking about how our military is still the best in the world, but it's shrinking in their capabilities. The number of ships that we have in the market in the whole world today is much smaller than it was just 10 years ago. A lot of our ships are getting older and older, so there's going to be a lot of money spent on that, and how are we going to pay for all of that? And, of course, people are still talking about another $1 trillion infrastructure improvement program. That's great to have. Obama tried that. It didn't really provide a lot of overall benefits, but it did get us out of the recession. Who's going to pay this $1 trillion for infrastructure? But we need infrastructure improvement. A lot of the bridges, the roads, the big cities are falling apart. We need infrastructure improvements. How do we pay for it? According to Trump, he thinks he's going to be able to pay for a lot of this by increasing the overall business in the United States, bringing more people here, producing things more effectively. We'll have to see if it works, but there's not enough money to keep spending on health care, immigration, tax reform, military reinforcement, and infrastructure. unless we find ways of cutting costs or bringing in more tax dollars without taxing the poor or the rich much higher than it is already today. And again, his approach is more business, more employment. We'll bring in the money to do it. Hopefully it will.
Well, outstanding. Well, thank you so much, Mark. This was really a very interesting webinar to be doing right now when all of this is really just so very felicitous and current. We always appreciate your insights for sure. We definitely have a time for a few questions here. We're also going to open up a brief poll for those of you in the audience. If you don't mind clicking through that, we really appreciate it. Mark, we did have a couple of great questions come in during the session here. One I'll lob at you right off the bat. Is there any conversation about alternative health modalities, acupuncture, chiropractic, naturopaths, home birth, etc., being a part of these changes in cost and quality, or is it centered around hospital care?
I think it's going to be centered around what is the best care for the lowest cost. Therefore, I think hospital care is going to be looked at as a heavy cost, and we're going to be looking for alternative healthcare programs, acupuncture, telemedicine, again, engaging the patient in their home. There's a lot of things we're seeing. We've even seen programs where somebody who ends up having back injury now can go in for massages, just basic massage, and getting covered for that because the outcomes are better. And the outcomes is, can that person get back to their job quicker by not only having acupuncture, chiropractor, and massages? It's all going to be about lowering cost and improving the overall outcomes. So I think everything is now open. And a lot of the programs that were not paid for in the past on the medical care will be compensated under value-based reimbursement if they can show that the cost provides a value compared to the outcomes. And I think a lot of the other programs you mentioned out there are really good programs. I think they can really help the population lower costs too.
Very good. Another question that came in. As a doctor, I feel like Obamacare has changed the way we work, the way we collect, and the way we exist as professionals. I don't know how to fix it all, but I'm just hoping for some relief on the paperwork. Of all the filings, reporting, and data processing, this is worded a little oddly, they continue to burden our office more and more every year. Do you think we'll see any real change in that?
I hope so, because if you go back and look at the overall cost of healthcare, right now 32% of healthcare cost is paperwork. We got to find a way of cutting that back. And under Obamacare and the big push for the meaningful use, of course, all doctors were asked to or required to, if you want to look at it that way, to use EHR products. And we know a lot of the doctors found that the EHR slowed them down, depending on the product, and they didn't get the value out of it. Well, the value really comes now we have a lot more data, but we need to move from a data processing age to the information age to the knowledge age. Once we get knowledge about this data, we can cut back on a lot of this data we're collecting. We are collecting so much data that does not provide better outcomes or lower cost. We collect it because somebody said, let's collect the data. We report the data because somebody said we should report it. We got to step back and say, what data do we really need that's going to affect overall care, outcomes, and lower cost? And that's a tough one to step back on because, all these EHR vendors have created these great programs on collecting a lot of data. How much of this data do we really need? And how much of this data actually drives outcomes and quality improvement? We know reporting doesn't improve things, but if I can get the right information to the right doctor at the right time, provide them knowledge about a patient, then maybe we can change the way we practice medicine and take care of the patient the right way the first time and hopefully get better outcomes and lower costs from that. But we got to be able to provide the right data to the right provider at the right time. We don't do that today. We collect a lot of data today. So I agree with him. We got to cut back to 32% healthcare costs as paper-based or data-based.
All right, and we have, let's see, we'll do one more here. I know in the interest of respecting everyone's time, I know we are going to go a bit over the hour, but thank you all for sticking around, and you will, of course, receive the follow-up link to this in the recording if you want to revisit it as well. But one more question from Mark here. In our practice, our struggles with the ACA were less about the patients and more about the insurance companies. To me, the insurance companies still have far too much control over coverage and cost, and just aligning our care with coverage is a nightmare. Are there plans to reform health insurance that we can look forward to? So I think tagging health insurance more than health care, I know, but is there do we have something along those lines that'll
I think the challenge is, what are we going to force the health insurances to do? They've been forced already to start covering a lot of services that are not needed by certain individuals. So there's going to be some changes there. The question is going to be, what is a patient? What is going to be covered by that insurance plan? I think that changes under, as I mentioned, value-based reimbursement, because the insurance plan has a contract with the health system to take care of like a diabetic patient. And therefore, it's up to that health system, the hospital and doctors, to decide what they're going to pay for. The insurance companies won't have control over approving or not approving. The healthcare insurance is going to say, we're going to pay you X amount of money to take care of this diabetic patient, as an example, plus you'll get a 20 or 30% bonus on top of that if you improve quality. Now it's putting the control back to the hospitals and the doctors to decide what they want to approve, what they want to get done, and it's pulling the insurance plan out of that decision-making, which I think is going to be beneficial, as long as the hospitals and the doctors and the care providers that are out there are providing the best care for the lowest cost, because the insurance plans will say you can do as many tests as you want because you're paying for all of it. So we got to do the right amount of care, but do the right care. So I think under value-based reimbursement, we're finally allowing the physicians, the hospitals, all caregivers to make the decision on what care they want to provide, and it's taking the insurance plan out of that decision-making. The insurance plans will still be there for all the so-called healthy people, the people that don't have chronic diseases, but there's not a lot of health care going on for them. But you'll still have to go through the eligibility of finding the approval for what care they're going to provide, when they get physical therapy, that kind of stuff. But for the majority of the patients that have the majority of the cost, the people with chronic diseases, I think under value-based reimbursement, the doctors are going to be put in charge again. They're going to be able to decide what care is provided. They're going to decide what's going to be covered, what's not going to be covered. It's up to the providers to decide that. I think that'll be beneficial for everybody.
Excellent. Well, that's outstanding, Mark. Mark's contact info and resources will be included as part of your follow-up documents, and they're also on the screen now. You're welcome to reach out to him directly offline with more questions as they arise. And Mark, let me thank you once again for your time and your expertise today.
Thank you very much. Great talking to everybody. Have a good day.
And we'll now turn our attention to our sponsor, Care360. Care360 offers a complete end-to-end solution for all of your practice needs. We focus on the business side of things so that you can focus on your patients. We connect all manner of healthcare organizations, physicians, and patients to improve access to information and insights. You may already be familiar with Quest Diagnostics lab and diagnostic services, and many of you are currently enjoying our award-winning EHR. But our integrated approach to healthcare IT can cover your needs throughout your entire patient cycle. And because we're backed by Quest Diagnostics, you know that you can rely on a stable, proven partner. Our network is strong, connecting over 450,000 physicians and touching the lives of over a third of all Americans every year. The confidence and reliability that comes standard with every Quest Diagnostics Care360 relationship is easy to appreciate and to benefit from. Our holistic suite covers every aspect of your patient and practice lifecycle, from appointments and reminders, documenting a patient visit, verifying insurance and processing payments, and right through integrated follow-ups via our MyQuest patient portal. If you're looking for a complete solution from a single source, Care360 has you covered. Our electronic health record is an ONC-certified, award-winning product that works extremely well with small practices like yours. It is cloud-based with powerful mobile integration to your smartphone or iPad, allowing you to work wherever and whenever it's convenient for you. The practice management side allows your front office to work more efficiently to manage the flow of patients, keeping your practice organized and agile, linking directly to your EHR so that you can spend more time focusing on your patient and billable encounters instead of front office administration. And if you're considering an enhanced medical billing service, Care360 has an outstanding revenue cycle management solution for you as well. Few things are as time-consuming for your practice as billing and collections. Handing off the more monotonous busy work can free your staff to focus on patients instead of spreadsheets. Trust Care360 to provide you with a solution that's up to date on the evolving trends and changes in this industry. If you have more questions about Care360, please feel free to call or email using the contact information on your screen. And once again, we thank you all for your attendance today, and a special thanks to Mark Anderson and of course Care360 for sponsoring the event. Keep an eye on your email inbox for additional presentations covering related issues in the near future. And this will conclude today's presentation. Good day.
Healthier outcomes are now easier to embrace. We know you run a busy practice, and efficiency is top of mind. Discover 360 degrees of connection and support. Keep your practice on solid ground with a cloud-based EHR.
Care360 offers a full and fully mobile EHR that helps keep medical practices efficient and profitable,
while connecting to the larger healthcare community.
Join the network of over 300,000 Care360 providers in 90,000 locations and connect to other healthcare providers as well.
Coordinate care to and from anywhere.
Care360 integrates providers and technologies across sites and care settings,
while seeing and sharing the bigger picture.
Care360 allows you to send patient information using the CCDA industry standard format, accept information from other providers, and access extensive patient lab histories to help optimize care.
Meet meaningful use requirements.
Care360 EHR is ONC certified to qualify for meaningful use,
while exchanging data simply and securely.
Physicians collect and share data with other EHR users to meet industry requirements with Care360 Data Exchange.
And with new Care360 Revenue Cycle Management, you can maximize collections and revenue.
Care360 provides you with a team of billing experts to take complicated billing issues off your plate, allowing you to focus on what matters most, your patients,
while reducing your administrative burden. And that means more time with patients. Care360 also offers many other great advantages. Boost patient engagement and compliance with MyQuest.
Patients can view and share vital health information with their healthcare providers.
Elevate patient conversations with interactive insights.
Enhance lab results with diagnostic insights, accessible in Care360 and to patients through the MyQuest patient portal.
That's 360 degrees of connection and support, and healthier outcomes for all. Care360.